Good morning, I'm Dr. Anas Al-Zahar, a general practitioner in DPRC. Today I will talk about orthostatic hypotension. When autonomic reflexes are impaired or intravascular volume is markedly depleted, a significant reduction in blood pressure occurs upon standing, a phenomenon termed orthostatic hypotension. Orthostatic hypotension is more common in older patients and may affect up to 20% of patients over the age of 65 years. Orthostatic hypotension is a risk factor for cardiovascular and all-cause mortality, can cause falls and attendant morbidity, and is associated with cognitive decline as well as comorbid psychiatric symptoms. Orthostatic hypotension is a feature of autonomic dysfunction that may result from certain neurodegenerative diseases affecting the central and peripheral nervous system, as well as certain peripheral neuropathies. Orthostatic hypotension may result from volume depletion due to diuretics, hemorrhage, or vomiting. The use of antihypertensive and other medications often contributes to orthostatic hypotension, particularly in older adults. Symptoms of orthostatic hypotension typically occur in response to sudden orthostatic change, but also after meals, exertion, and prolonged standing. Orthostatic hypotension can be asymptomatic or symptomatic. Symptoms can include dizziness, lightheadedness, syncope, muscle ache in the neck and shoulders, and even angina. Symptoms of orthostatic hypotension vary in severity, from mild to incapacitating. Severely afflicted patients are unable to leave the supine position without experiencing pre-syncope or syncope. Orthostatic hypotension is diagnosed when within 2 to 5 minutes of quiet standing, after a 5-minute period of supine rest, one or two of the following is present: a reduction of 20 millimeters or more in systolic pressure, a reduction of 10 millimeter or more in diastolic pressure. For patients diagnosed with orthostatic hypotension, further testing should be performed to identify treatable conditions that may be causative or contributory, in particular medications and potential volume loss. The goal of treatment for patients with neurogenic orthostatic hypotension is to attenuate symptom burden and the risk of falls and reduce target organ damage and mortality. Treatment is geared to prevent or alleviate symptoms and their impact on daily function, rather than a target blood pressure. We start with a non-pharmacologic measures for asymptomatic patients and those with mild symptoms. Patients who are asymptomatic may require education and non-pharmacologic measures only. Medications are added for those who do not respond to non-pharmacologic measures or have more severe symptoms. The non-pharmacologic measures include discontinue exacerbating medications, increase salt and water intake, modify daily activities and lifestyle, use compression stockings and abdominal binders. The pharmacotherapy includes initial therapy and second-line combination therapy. The initial therapy include fludrocortisone, sympathomimetic agents like alpha-1 adrenergic agonist midodrine, and the norepinephrine precursor droxidopa. And finally, norepinephrine transporter inhibitors like atomoxetine. Second-line combination therapy for patients with a suboptimal response to initial monotherapy, we typically add a medication that may exert a synergistic benefit. For example, a sympathomimetic agent may be used in combination with fludrocortisone.